Thanks to the organizers for having me here. I'll dive right into my talk because we are running behind schedule. So my talk focuses on stewarding antimicrobial stewardship with data. And you'll hear this almost throughout my talk about data, and data. And this is a summary slide that I just put up front so that if we don't have time later to talk about all of these, but how can we use temporal data? And the keyword here is temporal. When we are looking at antimicrobial stewardship, we have to have time into perspective as well. So having temporal data sets and temporal models for tracking antimicrobial susceptibility, how can we have more proactive genomic surveillance, and how can we have rational use in the ICU settings? This is by no far an exhaustive list of what we need to be doing. This is just a list that we work on in my lab. And the key message is obviously measure, model, control. So along with these three directions, I have three short pieces that I'll cover during the next 10 minutes or so. The first one is on temporal data and models. This work started way back in 2019, actually, when we were participating in the Welcome Data Reuse Challenge, which had released data from more than 70 countries on AMST isolates. More than 600,000 isolates were available openly. And these data were from 2004 to 2017. And what we did in this data was to basically lay the context of AMST isolates along with what we could find from other indicators around the globe. For example, the governance. So these are all indicators from World Bank and global burden of disease. So the thought was that AMR is a systems level problem. We don't know what buttons we need to push to really change the scenario. And can we learn something using AI along these lines? And this was the first network I remember that came up using a Bayesian networks approach. You can see these are directed graphs. And interestingly, when we did this kind of analysis, the world governance indicators, and this link is not visible because I think of the brightness, but there are links here which actually link up antibiotic resistance with governance and also antibiotic resistance with global burden of disease. In this paper, we talked about how we should look at these aspects also and do some kind of counterfactual analysis, which is causal analysis to understand impact. What would happen if I changed the level of immunization in high-income countries? What would happen to Acinetobacter baumannii? And what would happen in middle-income countries? Unfortunately, there were very few low-income countries in that. And we immediately see in this trail of analysis that we see there's a huge difference of effect size that is observed in middle-income countries and high-income countries, essentially indicating the need to make effective interventions in these countries. So this work continued on to a collaboration with the Indian Council of Medical Research, ICMR, where we were working together, and Professor Balaji is here, is also part of this work, where we were using similar strategies to understand data from 5 years, 2017 to 2021, on data from 20 sites all across India, more than 200,000 isolates, including blood and urine isolates. And the key things we were asking was, can we use data-driven understanding to guide policy in this direction? And again, this is a summary graph which shows that what trends and associations we were looking at and how do we embed that in the graph. And this is how it looks like. For example, for Klebsiella UTIs, you see a mild trend, but it is mildly visible. But is there something really present there? And you see a lot of cyclicity as well. So when we do these analysis, temporal analysis, we need to take into account these changing patterns as well. So this is a decomposition of that time series into seasonality and trends. And after we have adjusted for all those, we see an alarming trend. And this is a trend for imipenem for Klebsiella. And we saw almost 0.03% per month increase in resistance to imipenem in Klebsiella UTIs, which to us, I mean, this paper is under revision. The preprint is available online. So you can look at some of these details as well. The next thing we asked was, okay, there are these time series. We also have understanding of which isolates are community-acquired infections and which ones are hospital-acquired infections. And we have time series that look like these. Can we do a lead-lag analysis to understand what is leading what, right? So is community leading the hospital resistance, or is it the other way around? And here is a lead-lag analysis just to indicate, so 0 means there is no lead-lag relationship. Anything other than 0 is, this side is leading, that side is lagging. So basically you can see that hospital-acquired resistance in imipenem is leading community-acquired resistance. Again, a piece of evidence from our data directly showing that there is a transmission from community to, from hospitals to community in Klebsiella. The direction is reversed, of course, in E. coli UTIs as expected. More details are there in the paper. But again, some of the first pieces of evidence that we could glean using data analytics and models to understand these kind of patterns. Here is E. coli UTI, and there's also a link between antimicrobials. And the key question here is, do we have some indicator drugs which we can have a surveillance upon to indicate that imipenem resistance is emerging? And there are, and some of these, for example, for amikacin is a good indicator, leading drug for cefazolin resistance in this data, for example, because you see that the lead is on the amikacin side. Most of the bars here are, and these are lines of, these are the bars of significance. Then we embedded these data from 5 years in the context of the achievement of SDGs in these states, wherever these hospitals are situated. And Niti Aayog, which is the Planning Commission's new version in India, basically releases this report on SDG indicators, and the states are classified as front runner, performer, and achievers, and so on. And here what we did was basically again a Bayesian network analysis, just like the first analysis that I was showing, where we say that is there a relationship between antibiotic resistance and achievement of SDGs in these states. And again, for the first time, in a data-driven manner, we have a clear evidence that, for example, carbapenem resistance and the achievement of SDG 3 are linked together at the data level. And these are completely different data sets. But we find, we find robust patterns here that are consistent. More importantly, we see that states which are better performing on SDG3 have a lower carbapenem resistance. Similar analysis has also been done. This is a paper under review where basically we show similar findings for bloodstream pathogen sepsis. Again, SDG3 and imipenem come up there robustly as a strong component. I'll switch gears here to the second piece, and this is that was more of the hospital isolate surveillance. Here it is more of genomic surveillance, something again hospitals can do. Here we don't have data on AMR, but we have learnings from COVID-19 pandemic, and I would urge the group here to think about it in the context of AMR going forward. So this is the publication that is you can refer to while I'm presenting this work. The key idea being, can we learn to look at the sequencing data and read it like a book, just like large language models like ChatGPT do for text? And this was an exploratory thing that we started way back in 2019. But as we were proceeding, we actually found some really interesting insights. So using large language models, we analyzed 17 different countries. We were able to recapitulate the phylogenetic distances between sequences. So essentially some qualitative analysis that showed us that these models were learning the grammar of changes at the codon level in these sequences. These models were trained on more than 3 million sequences deposited on GISAID database. So that was the strength of this work, that open data sets again, and an open call to really deposit AMR data sets as we are building these resources. But then we went on to ask the question that the grammar learned from these models, is it any useful other than just recapitulating phylogeny of the evolution of the virus? And we have some features which I don't have time to go into, but again, a lead lag analysis of the kind that I showed you earlier. Question being, is there a leading relationship between any grammar pattern and the surges in cases. And we see that in 7 different countries, all statistically significant. We see a leading pattern in the entropy of a dimension 32, which I don't have time, as I said, to go into, but here is the pattern that you can see again. The blue is entropy of dimension 32. It rises, falls, and then basically we see a similar pattern in cases 2 months down the line. This is seen on the lead lag analysis also, statistical analysis also on machine learning based predictive model entropy dimension 32, which gave us confidence that there's something there. We look at dimension 32, obviously it has a lot of representation from codons, which are also known to be important from surges. But this allowed us to do proactive surveillance of case surges. Even for Omicron, we were 2 months ahead of time in predicting the Omicron surge in India, and we had a dashboard which was openly available. We now have another large language model which is which has better capabilities that we showed earlier, because it can actually learn emergent properties such as what happens at the protein level if the model only looked at the DNA level and so on. Again, I think this is something which is very interesting. This is just ready for submission and would be happy to discuss more. In the context of AMR, this is important because we could transfer learnings from what we learned in the COVID space to a new virus, MERS. And we could show that even if you have smaller number of sequences, for example, for MERS, we could leverage the learnings from COVID and apply to MERS. And that's called transfer learning in the context of AI. AI models do that all the time. So for AMR, it is also important that even if you have smaller number of data sets, we can actually transfer across these data sets and so on. My last 20 seconds, we'll talk about models that work in the ICU settings to predict outcomes, for example, shock and sepsis. This work has been going on for the last 7 years at All India Institute of Medical Sciences, a pediatric ICU, where we have now more than 2 million patient hours of continuously monitored data, heart rates, pulse rate, oxygen saturation, respiratory rate at every second resolution. High density data because we were able to build these IT platforms there. Models that are published, there's a series of papers which achieve prediction of shock more than 12 hours ahead of time. Some of these models have been actually validated in more than 200 ICUs, which are also adult ICUs, cardiac, surgical, and so on. None of these ICUs are in the Indian settings, mostly are American ICUs, so these are again transfer learning. Again, we need to learn more from the Indian settings in this case. These apps are also deployed. This is an app that is available online for neonatal sepsis, for early onset sepsis. And again, we showed in this manuscript that how much is the prevention in terms of antibiotic usage if we have early warning signals. So questions? I'll just end by saying that it's data, and data. I mean, major gaps are data. Technology, we should have point of care susceptibility testing, real-time databases, data-led stewardship, value-led engagement with practitioners. They need to see the value of data and of models. And how do we basically measure the effectiveness, of course, with data? So that's my lab, and I would like to acknowledge my funders, and I think I don't have time for questions, but I'll leave it here. Thank you.